Hey guys, I'm Aeshani, and today I'll be talking about cerebral edema, hydrocephalus, and intracranial hypertension. Starting with cerebral edema, it's basically the excess accumulation of fluid within the brain parenchyma, as opposed to hydrocephalus, where the accumulation of fluid is within the ventricles. And this is as a result of damage to either the blood-brain barrier or the blood-CSF barrier. The brain swelling that causes intracranial hypertension, or it can also cause severe herniation. There are four types of cerebral edema: vasogenic, cytotoxic, interstitial, and osmotic. We'll talk about these later. And you can diagnose the edema by imaging methods like CT, MRI, or you can monitor the intracranial pressure. For treatment of cerebral edema, we use diuretics. They basically reduce the fluid buildup by increasing urine output. You can also use steroids like dexamethasone, which decrease inflammation and swelling in the brain. And some osmotic agents can also be used, for example, mannitol or hypertonic saline, which basically draw the fluid from the brain tissue and into the bloodstream. You can surgically also perform decompressive craniectomy, which is you can also perform decompressive craniectomy, in which a large portion of the skull is removed, but temporarily, to allow the brain to swell without being compressed, which is super helpful for preventing herniation. There are also some non-pharmacological methods, for example, elevation of the head, which would promote venous drainage and reduce the intracranial pressure. You can also induce mild hypothermia, which lowers the metabolic demands of the brain and therefore reduces the edema. Or you can induce controlled ventilation. Okay, so let's talk about the cerebral edema types. The first one is vasogenic, which is caused by breakdown of the endothelial junctions. You can see this type in ischemic stroke. It can also be seen in space-occupying lesions like brain tumors, intracranial hemorrhage, and abscesses, or also in traumatic brain injury or inflammatory causes like encephalitis, and also toxic causes, for example, in lead poisoning. The next is cytotoxic, which is caused by the damage to brain parenchymal cells, which is usually either due to hypoxia, and it can be seen in either stroke or in hyperammonemia. Here, the blood-brain barrier is intact though. It's only not intact in the vasogenic type of cerebral edema. The third type is interstitial, where there's blocked CSF drainage, and you can see this in hydrocephalus or idiopathic intracranial hypertension. And the last type is osmotic, where the plasma osmolarity is lower than the intracerebral osmolarity, and therefore that creates an osmotic gradient, which causes the diffusion of water across the blood-brain barrier into the interstitial fluid. This one is seen in either hyponatremia or some iatrogenic causes. Let's talk about the clinical signs of edema. The signs match with a lot of signs from hydrocephalus or intracranial hypertension because somehow they're all related, of course. There is severe and persistent headache, an altered mental state where you can see confusion, disorientation, the patient is irritable. There's also risk of seizures, nausea and vomiting, and visual disturbances, where either it could be blurry vision, double vision, or visual field defects, with papilledema because of increased intracranial pressure. You can also see some respiratory changes, and this one in particular is called Kane-Stokes breathing, where there are periods of hyperapnea and then followed by apnea, and it keeps alternating. There's also, of course, increased intracranial pressure and the signs associated with intracranial pressure, which also include headache, seizure. There might also be some weakness or paralysis, usually one-sided, like hemiparesis or hemiplegia, or difficulty moving limbs. In severe cases, you can also see some abnormal posturing, for example, decorticate or decerebrate posturing, which indicates significant brain dysfunction. There's also bradycardia, seen as a compensatory mechanism in response to the increased intracranial pressure. So hydrocephalus is the abnormal enlargement of the cerebral ventricles and the subarachnoid space as a result of excess CSF accumulation. 60% of the cases are congenital and 40% can be acquired. There are two types of hydrocephalus, communicating or non-communicating, based on the etiology of hydrocephalus. In communicating, it can either be due to the fact that CSF is getting less absorbed or there is increased production of CSF. Low absorption can be seen in inflammatory diseases of the CNS, for example, in meningitis. Or you can also see it in subarachnoidal or intraventricular hemorrhage because there is fibrosis and it obliterates the arachnoid villi. Increased production can be seen in choroid plexus papilloma, which is a benign tumor of the choroid plexus, which is where the CSF is made. The non-communicating hydrocephalus is more of an obstructive hydrocephalus, where there is obstruction of the cerebral aqueduct of Sylvius, or the foramen of Luschka, or foramen of Megendie. The non-communicating hydrocephalus is the most common form of congenital hydrocephalus, and seen in some congenital malformations like Arnold-Chiari malformation or Dandy-Walker malformation, in which the fourth ventricle does not close completely. This causes a lot of neurological abnormalities like ataxia, along with the non-communicating hydrocephalus. Some other infections include congenital toxoplasmosis or some other intrauterine infections. There can also be some kind of cyst obstructing the intraventricular foramen or congenital stenosis of the aqueduct of Sylvius. The acquired causes usually include brain tumors, for example, medulloblastoma, pinealoma, ependymomas, or other space-occupying lesions, for example, brain abscesses, or if there is some big clot. The clinical signs of hydrocephalus are basically the signs of increased intracranial pressure, which include headache, nausea, vomiting, papilledema, abnormal gait, impaired consciousness, Cushing triad with irregular breathing, wide pulse pressure, and bradycardia, and also abducens nerve palsy. In infants, you can see macrocephaly because their anterior fontanelle is not completely closed, and therefore the brain swells up. There are also some developmental delays and behavioral changes in infants, but I don't think it's as important. There is a subvariant of hydrocephalus called normal pressure hydrocephalus, in which the intracranial pressure does not increase. This is idiopathic and usually seen in adults over 60 years of age. So as I said, the ICP is normal or only mildly elevated, and this is because the ventricular dilation compensates for the slow accumulation of CSF. Also, in old people, there is some atrophy of the brain, and therefore the ventricles are increasing, but the brain mass is decreasing. So the pressure still kind of remains compensated and normal. Clinically, you can see a classic triad of 3 Ws. Wet meaning urinary incontinence, wacky meaning dementia, and wobbly meaning gait apraxia. The gait looks something like broad-based gait with short shuffling steps. It's also called as the magnetic gait. And the patients have increased urgency and frequency of urination. There are no signs of raised ICP, and diagnosis can be made by imaging methods like MRI, or you can do a CSF tap test and analysis of the CSF. Another kind is Hydrocephalus ex vacuo, which is not a true hydrocephalus. In this, the ventricles and subarachnoid space appear enlarged, but that is due to the loss of brain tissue and not the actual enlargement of the ventricles. Therefore, the intracranial pressure and the flow of CSF are completely normal. This can be due to primary cerebral atrophy or some destructive lesions or degenerative disorders, for example, Alzheimer's or Huntington's chorea. Since the ICP is not increasing, the patients are usually asymptomatic. The treatment differs if the setting is acute or definitive. You can perform the interim drainage procedures. They are usually used for acute post-hemorrhagic hydrocephalus. So you can do either serial lumbar punctures or place a lumbar drain, which is usually done for communicating type of hydrocephalus. Or you can put an external ventricular drain for non-communicating hydrocephalus. You can also consider pharmacotherapy, but the benefit is limited. So you can use either diuretics or intraventricular fibrinolytic agents, which is usually for subarachnoid or intraventricular hemorrhage. The definitive treatment plan includes placing a cerebral shunt. It can either be ventriculoperitoneal, ventriculoatrial, or ventriculopleural. Ventriculoperitoneal shunt is the most common one. And basically, when you're placing a shunt, what you're doing is you're removing the excess CSF or you're diverting it from the ventricle to a body cavity. There's also some other surgical procedures like endoscopic third ventriculostomy, which is done for obstructive hydrocephalus. Or you can perform cerebral aqueductoplasty, in which if the aqueduct is either stenotic or closed, you can open it to allow the passage of CSF. So our last topic is idiopathic intracranial hypertension, which is also called benign intracranial hypertension or pseudotumor cerebri. It's predominantly seen in obese women. There's also some risk factors like certain medications causing drug-induced intracranial hypertension, which include growth hormone, tetracyclines, danazol, or excessive vitamin A. The diagnosis is done by Dandy criteria. So the criteria includes symptoms of increased ICP like headache, visual changes, pulsatile tinnitus, papilledema, also with absence of localizing neurologic findings on the neuro examination. There should be absence of any deformity, displacement, or obstruction of the ventricular system. Also, the patient should be awake and alert with no apparent cause of intracranial hypertension. So then it would be called idiopathic intracranial hypertension. The clinical signs include headache, visual disturbances, pulsatile tinnitus, cranial nerve disorders, as I said, abducens nerve palsy, and also back pain. For diagnosis, you use ophthalmic examination where you will see bilateral papilledema or some defects in the visual field test. You can also do an MRI, which would show unremarkable brain parenchyma with maybe possible abnormalities of the sclera or optic nerve. Also, maybe you can see an empty cella, which is as a result of the CSF displacing the cerebral tissue, mainly due to the shrinkage of pituitary gland. You can also perform a lumbar puncture, and it shows elevated opening pressure more than 20 centimeter of H2O. But the CSF analysis is normal with no signs of inflammation or any bleeding. Be careful with lumbar puncture because it's contraindicated when the ICP is too high. But for example, in a communicating hydrocephalus, there is no pressure difference between the ventricles and the subarachnoid space. Therefore, it poses very little risk of herniation. And the treatment options are either weight loss, acetazolamide, or indomethacin. Thank you so much for your attention, guys, and hope this presentation helped you.